practices and are used to treat diseases of human origin or animal origin. The WHO has reported that more than 80% of us in Africa rely on traditional herbal medicines for our healthcare needs. And in fact, I am one of those. Those who know me very well, my language is a bit blurred because I'm suffering from flu-like symptom, this particular medicine, which is a herbal drug. There's market for it. The worldwide annual market for these products, these herbal medicinal products, is estimated at $85 billion. And when I looked up yesterday, they are projecting that by 2027, it will hit $414 billion. I hope we would position ourselves for the share of it. Use of traditional herbal medicines for pandemics are not new. In China, traditional herbal medicine played a key role in the strategy to contain and treat SARS. I'm talking about the very first SARS in 2002, 2003, that originated in China and Hong Kong, spread as far as Europe, North America. Chinese traditional herbal medicine played a key role in this particular mini pandemic, if I should call it that way, because it's not the scale of what we're seeing today. The anti-malarials have been at the forefront of the fight against this particular pandemic, so they can't be left out. Malaria herbal drugs obviously started with the quinine originally from the cinchona tree in the Andes forest in South America, used in centuries to treat fever at the time, fever and respiratory infections. And then was, so this is a herbal, this is the bark of a tree, this is a tree. The products were sent to Europe and then quinine was isolated. And later on, chloroquine in 1934 was also derived from quinine and so on. Other anti-malarial drug of herbal origin is also artemisinin. Professor Yu Tu and co-isolated this in 1972, which was a game changer in global fight against malaria. So the herbal medicine or medicinal products have been with us for a long time and they are critical, they are very important. 2 decades ago, African governments, knowing the importance of herbal medicine and what we could derive, adopted a resolution urging member states to produce evidence on safety, efficacy, and quality of traditional medicine, because those 3 are the most are the challenges when it comes to herbal medicine in practice in Africa. On the back of it, WHO Africa region supported clinical trials that led to 14 countries issuing marketing authorization for 89 traditional medicine products, which have met international standards and national requirements and were incorporated into the essential drug list of those countries. So it means we have moved from being static into moving based on what we are hearing now. However, all these efforts, by the WHO and other African governments, by the WHO and other stakeholders, didn't get the attention of most African governments until the arrival of the Madagascar syrup. So the announcement of the Madagascar's president that his country had discovered a cure for COVID-19 pushed African traditional medicine into the global limelight. So we were all excited. I remember on radio discussion, people had asked the government, Ghana government, to actually import the Madagascar syrup for treatment or management of COVID-19. However, the exact composition of this syrup was not known, but the people were able, Madagascar people were able to export to many countries worldwide. It tells you how people quickly and easily embrace um, um, herbal medicinal products. The WHO Africa, in collaboration with CDC Africa, when I say WHO Africa, I mean WHO Africa region, regional office. And they formed, that's in response to the Madagascar president's announcement and the euphoria surrounding that particular herbal syrup. They formed the Regional Expert Committee on Traditional Medicine for COVID-19 in July last year, basically to test products like the Madagascar syrup and others that will be coming out from many countries for export, and also to speed up the processing, the testing, and so on. So it means the advent of the pandemic had, awoken or had brought us some opportunities, especially those who are researching into the herbal medicinal or herbal medicines, and also the herbalists and the herbal practitioners. So in the next few slides, I'll look at the herbal drugs used for COVID-19. In fact, a lot of herbal drugs have been used to manage COVID-19, depending on which country, depending on which region you are. But you bear with me that the anti-malarials were popular and are still popular. And I have, because of time, I have shortlisted some of them here, shortlisted 3 to discuss. Echinacea purpurea, or E. purpurea, popularly known as cornflower, is the first image here, this flowery one. It's a medicinal plant used by the Native Americans for centuries to treat respiratory infections, fever, and so on, even prior to the arrival of the Europeans. The other one is the cinchona tree, where quinine was derived. And the third is Cryptolepis sanguinolenta, which is this one. This is a West African plant, which is also being used for centuries to treat diabetes, hypertension, and then malaria. It's actually been approved by Ghana's FDA for malaria therapy. So the E. purpurea is a popular herbal medicine in Europe and America. As I said, it was used by the Native Americans to treat respiratory infections for centuries. The attributed mechanistic activities are interesting. This particular plant medicine has direct virucidal activity against enveloped RNA viruses. And COVID-19 falls within, SARS-CoV-2 falls within that category. Sharma et al. Also reported that this particular E. purpurea has anti-inflammatory effects. That is, they specifically inhibit pro-inflammatory cytokines such as IL-6, IL-8, and tumor necrosis factor alpha. And it makes it a perfect drug for the fight against COVID-19. So I wasn't surprised when last year a lot of papers showed or published that the effect of E species on the prevention and treatment of COVID-19 and other respiratory infections, because it was already shown to inhibit influenza A virus after the Spanish flu. And another paper that is Journal of Virology, I didn't put it in here, also showed a lot of interest in America and Europe of E. Echinacea purpurea. Then I would like to move from E. purpurea to the antimalarials, which have been shown to inhibit the replication of SARS-CoV-2. And you would bear with me that as of last year, chloroquine, hydroxychloroquine, and even now, we're very, very popular in the fight against COVID-19. There is a reason. They actually have direct antiviral effect, inhibiting the pH-dependent steps in the replication of many viruses, including influenza A, yellow fever, coronaviruses, and so on. Aside from, again, last year, politicians can be very powerful. The then President Donald Trump promoted hydroxychloroquine, and boom, it went global and became part of the standard treatment for COVID-19 for many countries, including Ghana. And if Professor Kwame Ohene Boabeng is actually listening, I'm sure during the discussion he will throw more light on the controversy of hydroxychloroquine and as to whether it works for COVID-19 or not. Aside from the pH-dependent steps that it inhibits, it also inhibits the powerful interferon alpha pathway. Assuming, let's quickly go through this cartoon, assuming this is the plasma membrane of a cell that an RNA virus like COVID-19 wants to infect, it attaches through a process, it is internalized. Now, when it gets into the cytoplasm, for RNA virus, not DNA viruses, there is what we call pattern recognition receptors that recognize them. One of them, a key one, is RIG1 and also MDA5 and so on. Once they recognize this, they start signaling events that promote the synthesis of interferon alpha molecules. These are potent antiviral cytokines. Now, what they do is once quinine sulfate is able to actually strengthen the surveillance, the recognition ability or capability of RIGI, and also promotes that leads to the promotion of interferon alpha. And this starts all this signaling mechanism culminating in the degradation of the infected viral RNA or RNA virus, such as COVID-19. But this particular pathway hasn't been as popular as the pH-dependent steps of replication that most of us have been talking about. But this is a critical pathway that the anti-malarials have capitalized on to degrade viruses such as SARS-CoV-2. So the third anti-malaria drug is what we call Libima out there, but it is Cryptolepis sanguinolenta. It is, as I said, an FDA-approved anti-malarial. It's been used in Ghana for centuries to treat malaria. I have worked on this since 2016. It has certain interesting properties. It possesses in vivo anti-inflammatory activity. It reduces bronchospasm, bronchial secretion, hypersensitivity. It boosts immunity. Fantastic characteristics of a drug if you want to target COVID-19 therapy. In our lab, we also showed that it exhibits direct antiviral activity in vivo and in vitro. This is actually currently under review in a manuscript under review somewhere. And we went on further to show that it actually augments the very powerful antiviral pathway we call interferon alpha by specifically targeting signaling proteins of that pathway, such as Janus kinases 1, transcription factors such as STAT1, STAT2, and so on. We were very excited. At the time we were generating this data, our colleagues at chemistry were also working hard around the time. And they showed that in fact, they corroborated our findings. They showed that Cryptolepis sanguinolenta inhibits SARS-CoV-2 viral proteins, in fact, in line with what we had. In fact, these are independent work by Lawrence Bokwe and his colleagues, chemistry. That was very exciting. A multidisciplinary, multi-faculty group came together to write a proposal to repurpose this particular herbal medicine for COVID-19 therapy. And that gave birth to the so-called KNC-19 project, led by Professor Ellis Osudabo, current Pro-Vice Chancellor of KNUST. So there are opportunities for this. In Africa, herbal medicine practice capitalizes on the rich biodiversity, plants, herbs, and so on. Just don't go further. Just look out there at KNUST campus and you know what I'm talking about. Traditional medicine is culturally entrenched, and you and I are aware of that. Easily accessible and affordable. I can give you an example. So a patient was asked to buy a drug, in fact, it's actually for cancer. And then it was going to cost the patient 15,000. And then for one of our works, the patient relative approached us, and then the patient was asked to take our herbal medication. So out of 415,000 approximately, the person used 400 Ghana cedis for the treatment. We even asked him to come around for further checks. He said, "Yo, it's okay, it's fine." So it tells you how we have embraced traditional herbal medicine, which is cheap, and we identify with that. Opportunities still abound. It's primary source of healthcare to more than 80% of us. It keeps indigenous knowledge passed on to generations, and the knowledge is here. It represents a multi-billion industry that can help boost the economy of many African countries if well managed. We know how much China, through artemisinin, how much they have had, the pride they derive from artemisinin when it came global. We can do that. However, there are challenges, and you know it, I know it. The majority of herbal medicine practitioners in Africa double as spiritualists. They operate in the informal sector, and they live in their own world, and they have their own philosophy. Lack of clinical trials to establish safety, efficacy of most traditional medicines. Another reason that regional grouping of African countries signed on to that declaration, which I'm not sure if it really worked well. Another challenge is one herbal medicine is purported to treat almost all diseases. So the public sometimes, are skeptical. Most traditional herbal medicines are not well labeled, and you are aware of it. They lack approval from regulatory agencies. The Madagascar syrup, for instance, failed to reach the very body for which it was established. That's the Regional Experts Committee on Traditional Medicine, to test the efficacy, the safety, and the quality of it. It never reached them for some reason. And then political interference with regulation. So you have somebody starts work, maybe an institution starts work, then politicians start putting pressure. Oh, have you not done yet? Oh, what is this? People are dying. And then also political propaganda. You have politicians push cures that are not scientifically sound. An example is the former Gambian president, Yahya Jammeh. And you remember what he claimed to cure HIV with a secret blend. And people trusted him, people believed him. And then as I talk today, they are in the court seeking redress because they were deceived basically. So we need to invest more, and it is not a secret. Research institutions working on traditional medicines are largely stalling out during phase 1 and 2 trials due to lack of funds to phase 3 clinical trials. These are very expensive. And you remember the vaccine companies like Pfizer, Moderna, AstraZeneca, When they got to phase 3 clinical trials, their preliminary data was exciting. That governments quickly said, oh no, move on to the communities. People are dying. Why do you have to wait for phase 4? You just have to go on. And that's how today people are getting the vaccines, because their governments even care for them. Regional Expert Committee on Traditional Medicine was set up in July 2020. It's yet to be utilized. It's yet to get the first herbal, a sample of the first candidate COVID-19 herbal drug for testing. It's yet to get it. Though COVID-19 presented an opportunity to invest in traditional medicine, African countries failed to make the necessary investment to fast track the process for some reason. And I say that if we develop the area of herbal medicine, we would get more or plow more resources back into developing our own scientific bodies, such as the Mampong Center for Plant Medicine and so on. And the value chain would improve and will be more resource and we'll all gain. Well, the way forward, I'm proposing that scientific communication and investment could get us there. I said earlier that most traditional herbalists do not. Of course, I recognize that there are herbalists who are scientists, but the numbers are few. And that's why I have persistently mentioned, and in the literature, they just mentioned traditional herbalists. They are in the majority. Do not understand the traditional herbalists who are not scientists, do not understand the science. So we have to help them as scientists. You have to help them. I have to help them. The Ghana Science Society has to science. Ghana Science Association has to help. The Africa Regional Body has to help. We all have to help if we need to get there. By explaining the scientific process and setting up institutions to empower them to regulate their own practices. They are all over the place. Each and everyone is doing their own thing. We also have to accelerate research into their product. Until we started working on Cryptolepis sanguinolenta, I didn't even know that it could be used for cancer immunotherapy. We have to build their capacity and formalize their practices. We have to invest in the area of traditional herbal medicine to boost local consumption and also exports. Chinese are making a huge amount of money from the export of herbal medicines. So just as the GSA is doing with this seminar, the WHO Africa region 3 weeks ago organized a webinar, and they met experts, those researching into herbal medicines against COVID-19, the stakeholders, and so on. Our KNC 19 team was represented by Reverend Professor Charles Ansah. He gave the talk on our behalf. And 3 weeks later, they looked at the gap and they decided to help. They realized that phase 3 clinical trial was almost non-existent when it comes to testing herbal medicines for COVID-19 and other diseases. So they developed protocols, sent it to us, and this would come, it would help, in fact, for those of us in clinical trials, the documentary work, working on documents for regulatory purposes is a nightmare. If you don't take time, you'll give up. But they have eased it. So that's why I'm saying that scientific communication and investment could help us. They basically ease this bit of it so that people can write for they can request for license and so apply for clearance from ethical clearance and so on. African governments must prioritize and commit to the development of traditional herbal medicines. In summary, I know I had a limited time. In summary, most of us rely on traditional herbal medicines for healthcare needs. There's a big market out there, over 85 billion. The Regional Expert Committee on Traditional Medicine was set up last year, and that is the beginning of something we should take advantage of. Empirical data on anti-malarials have contributed to COVID-19 response and are still contributing. The trust gap is huge. It's a huge challenge regarding the contribution of traditional medicine to the response of COVID-19. Majority of herbalists don't operate in the formal sector. Most of our governments don't care about them, and so on. We all need to come together. Politicians not allowing the science to drive herbal medicine is another issue. African governments shy away from investing in traditional herbal medicine industry for some reason. However, some of these countries were quick to purchase the Madagascar syrup. I'm not sure why. To get there, we need to communicate the science properly to these traditional herbalists, invite them to our meetings, let them be part of us, let them understand. We need to regulate and formalize their operations. We need to set up R&D units at the Health Ministry or Ghana Health Service and ensure it works with timelines. Thank you very much again for the opportunity to share information I have gathered in a few years that started working on herbal medicinal products. Thank you.
Thank you very, very much, Professor Mohammed Ntuchelu. And thank you for such an in-depth presentation on herbal medicines against COVID-19. There was a question in the chat section. I'll quickly read it for you, Prof.
Yes.
So the question goes like this. The speaker said some herbal medicines are approved by the FDA. Why is it not in use then? And are these medicines for prevention or treatment?
Okay, so thank you very much. And I thank the person who has the question. So what I said was that Cryptolepis sanguinolenta or Nebima is approved by Ghana's FDA for malaria. What I even forgot to mention there is that the Cryptolepis sanguinolenta was the first herbal medicine to be approved by our FDA. I hope you get me. So two things: FDA approved Nebima for malaria is only what I mentioned, and I failed to mention that Cryptolepis sanguinolenta or Nebima is the first herbal drug approved by our FDA for COVID-19 study. Thank you.
Thank you, Prof. I'm sure that other questions will come through, and when they do, I think there is a question. Okay, Prof, we will definitely read other questions from
when it's question times,
in due time. Oh, yeah. Dr. Badu's hand is up. So, Dr. Badu.
Yeah, okay. Thank you very much, Professor. It's a very interesting talk with a lot of insights, honestly. When you actually talk about working with chemistry, for example, I was going to say, I was actually going to ask that question, because I know chemistry can predict those proteins and chemicals that can actually be used to treat them. But my question to you really is, the patent of medicines in the whole world, the ownership of the patent that Africa owns is just about 1% of all the medicines that we use. Against the backdrop that the biodiversity from which these medicines come from, we own about 25%, perhaps the largest. But all Africa would do is talk about herbal medicines. They talk about the crude extract against this one, crude extract against this, crude extract against that. And we seem to have a penchant for looking for the crude extract activity against something. But all the medicines, herbal medicines or medicines of herbal origin that you mentioned, that are making names, you talk about quinine, you talk about artemisinin, all of them, they have been separated into pure compounds with proper dosage. Do you think, what will get us to that point? Would this crude extract, drinking half a gallon for treatment, or drinking 2 cups a day for treatment, will get us anywhere? Why are we not really looking into identifying the compounds and purifying them so that they can be used in a way that is accepted internationally. Because we do accept that China have a lot of herbal medicines, but they are not in gallons. Please, what do you think?
Thank you very much, my good friend. I mean, that's a very interesting question. It is also useful. Drinking crude extracts in gallons, I've been a victim of it before. And if you look at my slides where I said how we're getting there, we definitely will get there. We have to invest. Our governments, our educational institutions, it's about money. We will have to invest so that we move away from the crude extracts into getting the compound, the pure compounds, and even formulating such a way that we will maximize the profits. So investment is key. Investment in the science and technology is key. Getting the herbalists, going to them, educating them is also important. So again, Dr. Bedu, it is investment. It's all about money. If the money is not there, if my government is not giving me money, if there is no money anywhere, that's where I will end. Drink them in gallons and intoxicate myself. You find a lot of kidney problems in Konfanochi, partly because we drink too much herbal products in gallons, intoxicating our kidneys. So money investing is critical, and what GSA is doing is critical. Bring it to the attention of our government. We'll probably get there. Thank you. Over.
Thank you very much, Prof. As the discussion gets very interesting, we also have to be mindful of our time. So we will urge those who have more questions to please type them in the chat section. And since Prof is still with us live, he will do well to address your questions in the chat section. Please let us move on to our second keynote, which is coming from Dr. Lord Anthony Barson of Incas Diagnostics, Kumasi. Dr. Anthony is a medical laboratory scientist, a biomedical engineer, an inventor, and the founder and CEO of Incas Diagnostics here in Kumasi. And over the years, he has developed simple test kits for infectious diseases that largely affect women and children in Africa. And time wouldn't really allow me to read to your audience all the prestigious accolades that he has garnered for himself over the years. We are excited to have Dr. Lord Anthony Barson with us, who will talk to us today on the sub-team engineering technology called Pathways in the face of COVID-19. Dr. Lord, please, you have the stage.
Okay, thank you very much. I think what you didn't also mention is that I am in the Department of Medical Diagnostics in the College of Health Sciences, KNUST. I hope you can hear me.
Doctor, unfortunately, we can't hear you.
Oh, okay. Can you hear me?
Yes, we can hear you.
Okay.
Yes,
okay.
we can hear you, please.
All right, thank you so much. As I said, what you did not mention is that I am also in the Department of Medical Diagnostics, College of Health Sciences, KNUST. I'm going to be talking about technological and engineering pathways in COVID-19. And one of the things that COVID-19 showcased and highlighted was the myriad of technological and engineering innovations from Africans. What is interesting actually is the fact that most of these innovations that came during the pandemic came from very young innovators and not established companies as we are used to. And then while some of these engineering solutions were from the scratch, they were new technologies from the scratch, a lot of them were also simple modifications of existing technologies that had been also in use. What is very gratifying is that a lot of these innovations also came from academic institutions. And so at least one of the things that it proves is that given the right resources, our academic institutions could basically lead the technological and engineering advancements that are needed in our country and continent. In this presentation, I'll be highlighting a few of these innovations, and I'm also going to be talking about basically some of the challenges and the way forward when it comes to these technological and engineering innovations that happened during COVID-19. Okay, so we'll start with disease prevention. As you're aware, there are several aspects when it comes to COVID-19. So we had preventing the disease, and in preventing the disease, we are talking about hygiene, we are even talking about information and all of that. Then we'll come to diagnostics, then we would even come to disease management and tracking of the disease and all of that. In each of these sectors, there were a lot of innovations that came from young Africans. I'm going to highlight Africans, but when it gets to Ghana, I'll talk more on that. So we'll start with this e-transport system that was done in Ethiopia. So this e-transport system basically was meant to enforce social distancing in buses, and these buses were the normal buses that were being used in Ethiopia. But when COVID-19 came, they did an electronic system where only it could pick a certain number that had seats that were designed just to ensure that you went onto the right bus, and when you are on the right bus, you were on the right seat, and there were a lot of social distancing. These were some of the innovations that Ethiopians put in place. We also had a lot of use for drones. Sierra Leone, Morocco, Tunisia, they all use drones as a way of issuing announcements and enforcing social distancing. If a drone meets you in town and you're not supposed to be there, it would issue a warning for you to get indoors and all of that. In Ghana, drones were used to deliver samples to testing sites. In Rwanda, drones were used to deliver medical supplies and all of that. And all of these drones were, although they were already in the system, they were repurposed for the use during COVID-19. Veronica bucket, there were a lot of advancements in our Veronica bucket, which we had always been using. So for instance, if you can see on the picture, this is a solar paneled hand washing sink that was designed by a Ghanaian. There were also hand washing sinks that you could use your feet to operate instead of using your hands, because traditionally we've always used our hands to open the tap to get the soap and all of that. But during COVID, we're trying to prevent these things from getting to our hands. So people repurposed the Veronica bucket where you could use your hands. They were contactless ones where all you needed to do was just a sensor and you could wash your hands and all of that. All of these came from local innovators that thought about the problem of COVID and decided to do something about it. We also had cheap ventilators, these cheap portable ventilators that were designed. The one on the screen, for instance, was designed by the College of Engineering, KNUST. Students in Academic City University in Accra also designed one where they used wood. And all of these are innovations that came up to help with disease prevention. Finally, in South Africa, for instance, a bot was designed that could answer all the pertinent questions about COVID-19. So all you need to do is just send hi. It will give you a series of what would you like to know. So you type it and then it will give you all the answers. Funny enough, this was designed by a South African and it was finally adopted by the World Health Organization and it was being used. So all you needed to do was any information you wanted, you could get that. And all of these were technological advances that were targeted at disease prevention that were actually done by young Africans. When it comes to tracking the infection, for instance, in 2020, somewhere in March, the WHO AFRO, that's the regional office in Africa, they gathered 100 young innovators. And then they divided them into 5 teams, teams of 5, 20 teams of 5, basically. And we're supposed to develop solutions that were going to help with the tracking of COVID. So I had the opportunity to lead teams, a number of people from Senegal, from Cameroon, from South Africa, from Nigeria, and of course from Ghana. And we developed something called COVID Tracks, which actually won the hackathon at the time. And it was funded by WHO to take it forward. We actually, it's being implemented in 6 countries right now. And it's just a simple screening. There's a screening through the app, and then there's a classification between low risk, medium risk, and high risk. And we are able to track and map out movements of people based on their risk levels and all of that. And so this was something that we did as a multi-country collaboration when COVID came about. There are actually a number of apps that were developed that could track the infection as well. The Ghana government actually had the COVID-19 tracker. We also had lots of these apps that were supposed to help with contact tracing, that were supposed to help with COVID symptoms and all of that. The company Redbird, for instance, developed an app that could also help with taking you to the pharmacy and making sure that you do not have, if you have any of these symptoms, who you should talk to and all of that. So there were a lot of innovations around tracking the infection when it came to COVID-19. And then when it came to diagnosis, for instance, in Rwanda, they used robots basically to help with diagnosis. They also used GIS, home-based GIS systems, so that, again, it was color-coded so that those who tested positives, they know where their movements are and all of that, so that they're able to contain these movements. In other countries like Makerere University in Uganda, for instance, they developed these thermal sensors that could actually check your temperatures and all of that. And these were supposed to help with diagnosing the disease. In Ghana, Incas Diagnostics and KNUST came out with a COVID RDT. In Senegal, there was also a COVID RDT, which was developed so that it will cost less than $1. Makerere University, again in Uganda, also developed a COVID RDT. All of this as innovations to help with the diagnosis of the infections. Universities in Morocco and Nigeria also developed PCR reagents that were basically to help with the diagnosis of COVID. Now, when it comes to telehealth, for instance, there were a lot of telehealth apps that were already in the system. So things like Dr. Now and Bisa app were already in the system. But during COVID-19, there were an upsurge in their usage because a lot of people were making use of these. And these were highly effective in, first of all, containing the fear and answering all the questions that there could be. There were a lot of misinformation about COVID during the time. Even as at now, there's still a lot of misinformation about COVID, about vaccines and all of that. So a lot of people developed apps that could basically give them the right information. It would either take you to the right information, or when certain keywords came, it would do fact checking and tell you that this information is not true and all of that. A lot of the social media platforms also put in fact checking measures just to contain the lot of misinformation that was ranging about COVID and COVID-19. Now, so these are some of the examples of these technological and engineering pathways or innovations that came about with COVID. The major issues with how far these technologies have gone has been, first of all, with adoption. It's been very difficult adopting some of these technologies. And this has also been because of the fact that most African countries are basically used to importing a lot of these technologies. And so when we have technologies that come from Africans ourselves, we are a lot hesitant about taking those kind of technologies. It's very expensive to develop these. So sometimes these technologies developed in-house are also quite a bit more expensive than imported ones. And people like to go with those ones. And so that has been one of the challenges when it comes to adoption. Also, we've not had a lot of help from our governments, apart from most of the fanfares that come with these innovations and all the announcements that come with it, and probably being mentioned once or twice in the media. We've not been able to take most of these innovations forward because we've not had help from any of the sectors that could help. There's been lack of funding in a lot of them. They've developed these systems for the ventilators, for instance. They developed these systems, but you need to take it forward. You need to iterate all these innovations. Unfortunately, there are no funds to do that. And so they just become showcases in our universities and in other places where they develop them. We've not been able to take them forward. The second major challenge is that for a lot of these innovations, government is actually a competitor. So for instance, one of my friends had developed a contact tracing app and had piloted it in about 5 different districts in the Volta region and the Eastern region. And just before he launched his product, the government also launched its COVID tracker. And so basically what the government did was basically to shut him down. Because when government becomes your competitor, you cannot compete. Government is the biggest buyer, and all these districts are basically government. And so when government came out with this COVID tracker, he could not compete anymore. And funny enough, the government tracker could not also compete because, I mean, there was no time to iterate it. There was no time to further monitor and manage these apps. And so sometimes it is important that government allows these innovations to happen, and then government will be either the major funder or the major supporter or even the major buyer of these innovations, instead of being the business of also developing its own innovations. There are a lot of innovations developed by government that have basically either are not working properly or have basically collapsed, mainly because of the fact that there is no time and people to manage it to the way it's supposed to be managed. However, if it's a private sector owned innovation with funding attached to it, it's going to be managed very well. The way forward, I believe, is that we should start investing in homegrown technological solutions. In 2020, about $701 million was invested in tech startups in Africa. And these investments all came out of Africa. Governments did not invest in any of these technological startups. So this $701 million all came from outside. But it's also brought about a lot of employment. It brought about the needed dollars to show up the economies of these African countries. And all these investment, most of them were in Kenya, were in Nigeria, and were in South Africa. But there are a lot of companies in other African countries that are also doing a lot of innovations, a lot of things. But because we do not, first of all, there are no support from their governments, there are no support from regulatory agencies, there are no support from the people. They are not being highlighted, and so they are not attracting the necessary investment. And so it is time that government starts looking at homegrown solutions, technological solutions to our problems. Engineers are there to develop solutions. And so when the right investment and resources are made available, these solutions will come from local producers. And that is one of the ways where we can grow our economy. There's also the need for collaboration between academia and industry, just as what happened with our test kit. KNUST, which is an academic institution, collaborated with a local company, which is Incas Diagnostics, and we came out with this solution. So I think that when there's a lot more dialogue or a lot more collaborations between industry and academic institutions, will develop a lot more, which would then highlight the need for investing in homegrown technological solutions, which will take us forward. So thank you very much, and I would await questions if you have any.
Thank you very, very much, Dr. Lord Anthony Basson. Due to time, we would only allow for one question for Dr. Basson, but again, you can keep all your questions coming through the chat section. Please keep the questions coming through the chat section. Okay, so since Dr. Anthony is still online, he would address any questions that participants pose to him via the chat section. We will quickly move on to our third and final keynote speaker. In the person of Dr. Gideon Boakun, who is coming to us from the Office of the Vice President of Ghana. Dr. Gideon is with the Department of Accounting and Finance at the KNUST School of Business, but is currently on secondment to the Office of the Vice President of Ghana as the Economic Advisor and Spokesperson to His Excellency, the Vice President of the Republic. And he is therefore the right resource person to talk to us today on the socio-economic response to COVID-19. Please let us welcome Dr. Gideon Boakun.
Okay. Good morning, everyone. Can you hear me?
Yes, we can hear you.
Yes, I can hear you fine.
Well, thanks. And I must say it's a privilege for me to be with you to deliver the keynote address on the socioeconomic response to COVID-19. And as you said, I'm part of the university. Just that I've been away for some 3 or 4 years on secondment at the office of the president. And I'm glad to come back to the university in this particular format. I should begin by expressing my gratitude to the Ghana Science Association, the Kumasi branch, for organizing this seminar to engage stakeholders on the scientific implications of COVID-19 pandemic and the way forward. Indeed, as we all know, the topic is quite appropriate for this event. Promoting a science-based discussion of the socioeconomic development of Ghana in this era of COVID-19 pandemic is timely. You all know that COVID-19 has created significant global upheaval and also changed the lives of virtually everyone around the world. Beyond the health challenges, the pandemic has created significant socioeconomic disruptions across the world. It has pushed people into vulnerability, tested resilience, and threatened the gains made towards the achievement of the Sustainable Development Goals, the SDGs. The virus, as we all say, COVID-19 virus, which probably happens once in a lifetime, has caused some fundamental shifts in the global economy and disrupted social and cultural norms. Today, we no longer greet each other warmly and are continuously masked up as if we are at a masquerade party. That has become the new normal. In some circles, the COVID-19 pandemic has been described as a tail event or black swan event. Such events rarely happened, and when they do, they rest within the tail end of the probability distribution. Indeed, in 2020, 2020 has turned out as exceptional and will surely leave an indelible mark on our thinking for years to come. Colleagues, at the global front, the emergence of the coronavirus in late 2019 and subsequent explosion into a full-blown pandemic has been described as the most serious health crisis since the 1918 Spanish flu and the most economically costly in recent history due to global interconnectedness. It moved rapidly across borders along principal arteries of the global economy and catapulted a global health crisis into a global economic shock. The topmost public policy objective in a COVID-affected country was to strike a good balance between saving lives, which is a public health objective, and protecting existing structures that support livelihoods, which is an economic policy objective. This game theoretic objective, I believe, has challenged policymakers globally. Indeed, it is one that I strongly believe that John Nash could not have easily addressed with his Nobel Prize winning masterpiece on the Nash equilibrium. As the pandemic emerged and we all traversed the pathway with it, different countries have managed this challenge differently. Governments impose restrictions such as quarantines, border closures, workplace closures, social distancing rules to slow the rate of transmission and deaths associated with the pandemic. Although these public health countermeasures succeeded in flattening the COVID-19 curve, they also caused significant disruptions to global economic activity. We've seen global demand and activity fell sharply, exports decrease in both the advanced and emerging market economies, and almost halved in the large oil-producing countries. Thus, to address some of the adverse effects of COVID-19, in the case of Ghana, the government put in place certain socio-economic policy responses to mitigate the impact of the pandemic on the livelihoods of Ghanaians. One of the responses to the pandemic by government was the provision of free water a subsidized electricity bill for all citizens to help mitigate the impact. To contain the spread of the virus also, frequent hand washing was recommended by the World Health Organization as one of the most effective ways. Now we all know that with frequent hand washing under running water becoming a necessity and many families staying home due to pandemic-related restrictions, utility bills obviously, especially water and electricity, were going to increase. Government therefore, by means of response, absorbed the water bills for all Ghanaians for the first 3 months following the record of the virus in the country. We made sure that water tankers, publicly and privately owned, were all deployed or mobilized to ensure the supply of water to vulnerable communities. This policy initiative had one just objective: to cushion the citizens and ease the burden of water access on poor households who may compromise proper hygiene in the period of the pandemic because of water insecurity. Further, government of Ghana absorbed 3-month free electricity for the vulnerable and a 50% subsidy for all other consumers, residential and commercial. At the end of the 3 months, this initiative was extended to the end of the year 2020 as a measure to cushion the social costs of the restrictions imposed. Another response to the pandemic was reduction of the cost of mobile money transfers, interest rates, and required reserve requirements. The COVID-19 pandemic affected the remittances inflows that Ghanaians received. Like the situation in Ghana, several other countries equally experienced economic shock due to pandemic. Migrant Ghanaian workers suffered a decline in wages and loss of employment in countries such as the United States of America, Nigeria, United Kingdom, Italy, Germany, and Canada. To support the commercial needs of the Ghanaian economy and protect vulnerable persons who depend on their families abroad, the Bank of Ghana also introduced certain policy measures, including reducing the administrative cost of mobile money transactions to encourage increased transfers to recipient families and the waiver of fees for all mobile money transfers of less than 100 Ghana cedis. Also, the policy rate in Ghana was reduced from 16% to 14.5%. This was to reduce the interest rate charges on loans eventually by commercial banks and encourage businesses or the private sector to borrow from the banks at a moderate rate to mitigate the negative impact of the pandemic. In addition, the required reserve rate was reduced from 10%, and this is the required reserve rate of Bank of Ghana to the banks, to 8% to provide enough liquidity for the commercial banks to increase supply of credit to the private sector. Furthermore, the government paid attention to certain financial policies to revive the economy and therefore established the COVID-19 Trust Fund as a response measure to the pandemic. The overarching objective of all of these initiatives, especially from the side of the Bank of Ghana and its effect on the availability of liquidity to the banks, is that in a post-crisis or in a crisis situation like this, whilst people are losing income, national economies are losing income, governments ought to find ways to stimulate productivity by injecting cash into the economy. But you don't inject cash into the economy by printing new money, that will lead or have the concomitant effect of inflation. So the best means for government to go about this is to find ways to make money readily available in the hands of people. If we absorb cost of electricity and water, it means that the expenditure that people have to make, that money is staying with them, and then they can use it for other things. Reduce the reserve requirements of the banks. It means that how much of the total volume that they have to deposit at the Bank of Ghana, they have it in their vault, or can be turned into loanable funds to be given to the private sector and individuals when they need funds from the bank. So all of these were measures undertaken by government to ensure that we stimulate growth by making sure that monies are available for people to use. Government also received 45 million cedis in cash transfer from various institutions and organizations, as well as individuals during the inauguration of the fund. The accumulated funds were used to provide food for the vulnerable in the country, such as distribution of free meals to Kai, street children, and the ones that we can think of. The fund was equally employed to procure some PPEs, which are quite essential for the healthcare workers and healthcare facilities in the country to ensure they have adequate protective gadgets to fight the pandemic. The accumulated amount increased to about 53 million at the end of June 2020. Some of these were used in the acquisition of further PPEs or additional PPEs and other medical items to resource the country's frontline workers. We also all know about the 600 million cedis cap fund to support businesses who were greatly affected by the pandemic, of course. We saw the huge interest across the country for people to apply for the funds ranging from 2,000 cedis to 50 cedis and even 70,000 cedis. The interesting thing is that it's not everybody who got it, and obviously it's not everybody who could access such funds. Why others got it, others I'm sure have not been able to get it. Many people who depend on the SMEs in the country lost their livelihoods through the increased level of consumption of their savings due to partial lockdowns imposed on the two major business centers in the country. Hence, the financial support for these SMEs went a long way to revive the economy and provide employment opportunities for many people who lost their jobs during the height of the COVID-19 pandemic. The final response on the COVID-19 pandemic, as I reckon, was the issuance of a 3-month tax exemption package of an amount of 350,000 plus a 50% basic salary top-up for all frontline workers. The increment in the basic salaries of the frontline health workers serves as an incentive for their help in fighting against the pandemic. The incentives provided are necessary because the frontline workers are working extra hours and risking their lives in the face of the pandemic, and therefore needed to be encouraged. To conclude, the harsh effects of COVID-19 on lives contributed to the policy responses such as provision of water, subsidized electricity, reduction of mobile money transfers, establishment of COVID-19 trust fund, and what have you. These policy responses of the Ghanaian government have so far been positive and have contributed greatly to mitigating the impact of COVID-19 on the citizens. Of course, these are impacts that maybe you could say are recognizable just by looking at the amount that went out, the kind of measures that were put in place. And once we are within the academic sector, it shouldn't be out of place to kind of initiate some academic research on the practical impacts of COVID-19 mitigating measures on the lives and livelihoods of the people. For us as government, we still think we are not out of the woods. Although COVID-19 seems to have delayed our progress, it has not derailed it, and we still have a greater chance to navigate through this and come out of it successfully. Government is still on course in making sure that whilst we are providing all these social safety nets to people and the Ghanaian society, the critical aspects of the government structure that have to be put in place to make sure that every sector of the economy is developed is also well attended to, of course. There's always a limitation in terms of finances and how much resources government has at her disposal at any given time. Government remains committed to ensuring that Ghanaian lives are protected and swift, drastic, and decisive measures are taken to bring our economy back to life. This is what we are entrusted to do, and we shall do so to the best of our ability, hoping that we'll get the buy-in and the rallying around of the entirety of the Ghanaian populace. And with Providence on our side, we'll be able to go through. Thank you, and God bless you for having me for this particular seminar.
Thank you very, very much, Dr. Boakong. There is a question for you in the chat section, and I'll quickly read it to your audience. water bills absorbed for the first 3 months, but the bills have increased tremendously in the last few months. Is the government deceiving the populace?
I think I've heard this from two different quarters, that water bills have actually gone up, but I'm not too sure if that is the case, because as far as I know, there is a regulatory body that regulates utility bills, that is the Public Utilities Regulatory Commission. And before any such increases in bills can be visited on the populace, it has to go through the appropriate procedures for PURC to approve it, submit it to cabinet for approval, and where necessary for parliamentary ratification. As far as I know, no such thing has taken place. And so I've always told the two people who have approached me earlier on for that their bills have gone up, to say that go back and check with your electricity supplier if indeed it's a new bill or a new increase, or there is something that is really happening. I know before any such thing, and it is backed by law. I mean, nobody can just get up a day and say that we've increased electricity bills unless it goes through the proper regulatory body for the necessary things to be done. And I'm not aware of any such thing at the national level.
Thank you very, very much. So next on our agenda is a video presentation from Professor Mark Adomah-Samoah, the Provost of College of Engineering, KNUST, who unfortunately cannot join us live. But not wanting to be left out of this August discussion, Prof sent his recorded video through, which we are going to play for your viewing pleasure. Can we have the video on, please?
Good morning. I would like to thank the organizers of the 10th research seminar and poster presentation of the Ghana Science Association for inviting me to share some perspectives on COVID-19 pandemic, scientific updates, and the way forward. My name is Mark Adomah-Samoah, and I'm the Provost of the College of Engineering. My topic is COVID-19 pandemic, engineering and technological pathways. Outline of the presentation. I'll give an introduction. Then we will look at the case of COVID-19, the engineering and healthcare. We would also look at lessons from COVID-19 in terms of engineering and technological development. Then engineering and technological development in terms of proposed pathways will be discussed, and a brief conclusion would be given. COVID-19 was declared a global pandemic in March 2020. And since then, there's been a lot of human deaths and a very negative impact on economies of the nations. On 12 March 2020, Ghana confirmed the first 2 COVID-19 cases. And indeed, from 30th March to 19th April 2020, Ghana declared a lockdown on major COVID-19 hotspots. And these were mainly Greater Accra and Greater Kumasi. As of 21st April 2021, confirmed cases of COVID-19 stood at 92,166. And out of this, 777 unfortunately succumbed to the infection. The world continues to find ways of efficient and effective means of preventing, diagnosing, and testing of COVID-19. This presentation will seek to highlight the contribution of engineering in the fight against COVID-19. And with this, we'll be looking at the role that engineering is playing in prevention, diagnosis, and the treatment. We will also finally make recommendations on how engineering can play a stronger role in the fight against COVID-19 and in improving the healthcare delivery of Ghana as a nation. Engineering innovations have always been at the center of healthcare delivery. And this has actually been from the very simple equipment such as thermometers to the sophisticated computerized tomography known as CT scanners. In terms of COVID-19, the story is no different. For us to be able to fight COVID-19, we first need to look at preventive measures. The World Health Organization actually came up with some preventive measures which have been adopted by the Ghana Health Service. And these include washing of hands with soap and water, wearing of nose masks, social distancing, that is avoiding crowds as part of it, and then isolation of infected persons, which includes isolation centers. In order to ensure the prevention of COVID-19, engineering has played a major role, and inventions such as automatic hand washing station, which has been done by several people, including the College of Engineering of KNUST. That a picture being shown on the left, it is solar powered. We've also had the production of nose masks, which is being done worldwide. As part of prevention, we've been organizing virtual events that is to prevent crowding. And a typical example is this seminar, which is being held as a virtual conference. So engineering innovations have been used to undertake virtual learning, conferences, and work from home schemes. We've also had engineering inventions in the manufacture of disinfection chambers. And on the right is a locally made disinfection center in Kumasi. Diagnosis has also been an important part of our fight against COVID-19. And with this, PCR analysis equipment have also been manufactured. We have used engineering and biomedical sciences to interface strongly in our fight against COVID. Thermometer guns for non-contact temperature measurements have also been manufactured. Treatment of COVID-19 has also employed inventions such as ventilators. And on the left, we have a locally made ventilator by the KNUST College of Engineering. We've also had mass production of medical oxygen cylinders all over the world. With treatment, Ghana, through the effort of government, has been able to construct the Ghana Infectious Disease Center in record time. And these have been done, these and similar monuments have been done all over the world in the treatment of COVID-19. Engineering innovations, therefore, as have been proved already, play a vital role in the management of COVID-19 pandemic. As an extension, we also know that the SDG 3, which is good health and well-being, is also being driven by engineering innovations. Lessons from COVID-19. From the engineering and technological perspective, we've had some strong lessons to be learned by Ghana and the other developing countries. Local mastery of critical skills and technologies is very important. As a nation, we must prioritize the welfare of our citizens, and therefore, we need a minimum level of self-sufficiency in terms of engineering and pharmaceuticals as an urgent matter of national security. There are a few proposed pathways. These are substantially increasing the investment in the development of engineering skills so that we will be able to have efficient healthcare delivery. We also need to establish research and development centers, and these must concentrate on re-engineering and reverse engineering into biomedical equipment and instrumentation. Young engineers must be encouraged to undertake business incubation services. And with this, we still would like to look into medical equipment and bio-instrumentation. In this case, we'll be expecting Ghana to have our own versions of Siemens, General Electronics, and Abbott laboratories. Research and development in the area of biomedical equipment has already been stressed. We need to look at the manufacture of ventilators and diagnostic equipment. Nations that have mastered various technologies consciously invested in their processes. In conclusions, as I've shared a few perspectives, we need to look at the fact that COVID has taken a huge human and economic toll on the nations and on the world as a whole. Engineering innovations have played and continue to play a key role in the management of COVID and other healthcare deliveries in general. We must also understand the need to localize various technologies and skills. Ghana as a nation must consciously invest in our people and our systems to reduce reliance on foreign technologies and expertise. With these few perspectives, I thank you very much for your time and for listening to me.
Okay, thank you, Prof, wherever you are. I can see that there are quite a lot of interactions going on in the chat section, which is very encouraging. Thank you to those who are asking the questions, and thanks to our speakers for making time to address these questions. Next, we want to welcome Dr. Alimatu Sadia, who is giving an oral presentation on assessing the influence of COVID-19 on the attendance and punctuality of healthcare workers in a developing country. If Dr. Alimatu is with us, can you please share your slides with us? Thank you.
Thank you very much. Actually, point of correction, I'm not a doctor. I'm actually currently a PhD student with the School of Business. And thank you for the opportunity. So please, can you hear me?
Yes, we can.
Okay, so my name is Alimatu Sadia. I'm from the
Very
business.
loud and clear.
Okay, thank you very much. And I'm presenting on behalf of myself and my two other co-authors, who are Yakub Musa and Emmanuel Dogri. We are looking at the influence of COVID-19 on attendance and punctuality of healthcare workers in a developing country context. And Ghana recorded our first case, just like Prof just said, on 1st March 2020, 12th March 2020 rather. And 3 months into that, we had 10,856 recorded total cases. The World Health Organization declared COVID-19 as a global pandemic, and it also stated that healthcare workers were frontline fighters in the fight against COVID-19. And as a result of that, the availability and the punctuality of facility-based healthcare workers in testing, diagnosing, treating cases and then suspected cases was very crucial in fighting the pandemic. So as a result of that, we sought to look at how attendance, punctuality, and then hours spent at work of facility-based healthcare workers has been influenced by the rise in cases, because obviously the cases, total number of recorded cases only kept increasing. So how has the pattern using at these variables changed from January to June 2020 as we continue to record increased number of cases? So we collected data from one healthcare facility in the Eastern region, specifically St. Dominic Hospital. And the data was biometric records of attendance, lateness, and then absenteeism of 346 healthcare workers from January to June 2020. We analyzed data with Microsoft Excel and basically presented our findings in descriptive diagrams. And we classified the workers according to their job roles, because according to a study that was done in 2020, it was found that the job role of a healthcare worker could actually influence or could actually be a direct predictor of their risk of exposure to getting infection. And the study particularly said that about 38% of infections in the healthcare sector was coming from nurses. And they were, as a result, at the highest risk of exposure. So this is what we have for number of hours worked. As you can see, from January and February, the number of hours worked for nurses at the facility was basically high. But then from March all the way to June, we saw a drop. And as of June, we have still not been able to get them to work at the number of hours they used to work before we recorded our first case. We can see that too among mortuary workers, basically across board. Everybody seems to have dropped the number of hours that they were working since we started recording COVID-19 cases in the country. Then we're also looking here at the average days of absenteeism among workers for the 5-month period. And we can see that again, for nurses, absenteeism rose. In the last 2 months that we looked at, it rose significantly very high. And even in the first 2 months following the first case being recorded, absenteeism was slightly high. But then for the last month, it was significantly relatively higher. But interestingly, for doctors who are represented in the medics group, doctors and then physician assistants, absenteeism dropped significantly very low. Then punctuality, we would also see that for nurses, again, punctuality had dropped for the period that we are looking at, that you can see from the chart. And for medics, doctors, punctuality had risen. And this is just a correlation of the variables we are looking at. You can see that from the table on the screen, the working hours of nurses actually dropped as cases rose. Absenteeism kept rising with increase in number of cases, and then lateness or punctuality also dropped as cases continued to rise. It is same for healthcare assistants, and then like we said, for doctors, there's a little change. So our conclusion is that depending on the risk of exposure, as the number of recorded infections increased, healthcare workers reacted differently to the incidence of COVID-19 infections. And we are recommending that to ensure that, or to help generalize findings, this study can be replicated in a developed country context, or it can also be replicated among other essential worker groups who might be exposed. And then also other studies can adapt the survey method where more facilities can actually be put into the study. And also the mixed method can be used where you can, for example, use interviews to be able to get some nuanced responses, which this study might have mixed. And these are the limitations. It was basically quantitative. We didn't get to hear the side of the respondents whose data we used, and it was largely a descriptive study, which means predictability of whatever we tested can't be actually statistically tested or proven. And also just one healthcare facility was used. These are my co-authors and myself here. Thank you very much for the opportunity, and I'll still be online for further discussion. Thank you very much.
Thank you very, very much. There is a comment in the chat session which I would like you to comment on. And someone is asking, well, someone is actually passing a comment that probably because of the 50% increment in salary of frontline workers, that's why their work time did not decrease. What do you think, Sadia?
When it comes to worker behavior, I think I should mention that this study was based on the open systems theory of business management, which states that organizations and their actors react to changes happening around in the environment within which they exist. So when it comes to worker behavior, predicting it is quite complicated. And like I said, that's why I had mentioned that a qualitative study or a mixed method approach would be good. Until you hear from the side of the respondents whose data was used, then you can actually make sweeping conclusions on that regard. So we still don't know exactly what.
Thank you very much for your response. We would like to acknowledge the presence of some distinguished personalities. The Provost for College of Science is here with us. Professor R.C. Abedu is also here with us. We'd like to acknowledge your presence. You're welcome, sirs. Let's move on to our second oral presenter, who will be talking to us on a mathematical model for epidemiology of COVID-19 in Ghana. He's in the person of Dr. Benedict Barnes. Doc, can you please project your slides for us? In the meantime, there is a question for Sadia from the Provost. I would like to read the question to you, Sadia, if you're still with us. What informed your choice of that hospital and why only one hospital?
Thank you, Prof, for the question. Actually, when it comes to getting access to these types of data, it's difficult because hospitals might not be comfortable giving you this. And my second co-author is actually a manager with the hospital. So he was able to get us that. So we tried, but then we were not able to get other hospitals to sign on to the project. That's why we had to just restrict ourselves to just one hospital. And our choice is that it's a major hospital in the Eastern region. If you look at the number of the staff count, you can see that it's quite significant. And then they were recording cases, and probably we're thinking that using it would be a very good case for such a study.
So just a follow-up, do you think that your results will differ or will be different if you had sampled more hospitals rather than just the one which you sampled?
I don't think the results might differ if we use, because the hospital that we actually used is a major hospital in the region. So I'm thinking that we don't think that our results would have differed if we had used or increased the sample.
Okay, thank you very, very much. Dr. Barnes, if you're ready, please.
The presenter is muted. Please inform the presenter is muted.
Okay, so it looks like we can't hear Dr. Barnes's presentation.
The presenter is muted. Please inform the presenter is muted.
Okay, so in the meantime, while we wait for Dr. Barnes
so it looks
like we can't
his
hear
microphone,
Dr. Barnes'
let us have this
presentation.
short
Interactive exercise. I have three puzzles, which I will share on my screen.
The presenter is muted. Please
I hope you can all see my screen. All right, so you have basically 15 seconds to answer the question. There are three questions at the end, either one. So please type your answer in the chat section. Alternatively, you can also join by going to menti.com. You can go to menti.com and use the code that you can see on the screen. The code is 9877280. Please go to menti.com and use the code 9877280. And please include your name so that we can see the winners of this short exercise. Menti.com, code 9877280. So we have 2 participants so far. Yes, you will see the question very soon. We want more people to join before we start. Okay, so let's start. Fifteen seconds. Okay, so let's see if anyone got it. So the correct answer is mass. So a Christian priest's favorite part of physics is mass. Okay, the second question. Okay, so Sadia said Venus, but I don't think we can use Venus to measure heat. Mercury. So So Mercury is a god planet and can be used to measure heat. The final question. Okay, I think, yeah, so we've got a few correct answers, Frederick Asenso, and a few others. Well done to all participants. I think Dr. Barnes is ready, so we will ask Dr. Barnes to share his screen. Okay, so I think we're still having challenges with Dr. Barnes' microphone. So in the meantime, why don't we still go to Mentimeter? And this time round, so ment.com, and this time round, describe our experience at this year's Ghana Science Association webinar with just one word. So please go to menti.com and use the code 38636425. So please go to menti.com and use the code 38636425. So the code once again is 38636425. Okay, so we have some comments coming through. Educative, awesome. Interactive from Vivian. High tech. Well, in the era of COVID, you have to go high tech if you want to have intellectuals meet for intellectual discussions. Insightful, interesting. Educative. Inspiring. Okay, thank you very, very much for your comments. I believe that Dr. Barnes is ready for his presentation. Okay, in the meantime, please, you are informed that our posters is still online, and you can follow the link in the chat section to view the posters. Please remember that we need your comments regarding the posters, since there will be awards given out at the end of today's session. Now, I believe that we've learned a lot today from herbal medicines and how they can harness, how we can harness their use by making them safer and more efficient through investment, through how we can use emerging technologies to foster an inclusive COVID-19 recovery. And finally, the role that the government of Ghana has played in alleviating the burden placed on citizens by the raging pandemic. At this point, we would like to move to our poster viewing. So please follow the link in the chat section for the poster viewing. So I would like to briefly walk you through how you can get to the poster site. Please go to GhanaScienceKumasi.org, GhanaScienceKumasi.org. Okay, and once you're there, you can click on the view poster which will take you directly to the poster viewing page. So we've got quite a number of posters here, and you are at liberty to view any poster that excites you. So just to repeat, please go to GhanaScienceKumasi.org. So it will take you to this landing page and click on View Poster. Okay, alternatively, you can just click on the link in the chat section. So we have 10 minutes for the poster viewing. Okay, so it looks like Dr. Barnes is ready. So please let's listen to Barnes.
Please, we can't hear you. Can you unmute your mic? Unmute yourself, please.
Hello, can you hear me? Yeah. So, as my colleagues have presented on the origins of COVID-19, which started in China, December 2019, and spread to the other countries. This disease has been declared a pandemic. So it moved from one geographical area to another and caused by the novel coronavirus. And as of now, there are some vaccines which we hope that it may go a long way to prevent people with disease. But the coronavirus has brought a lot of effect on individuals as well as the society. Most countries have lost people, which has really affected the labor front. And also government has been giving some support incentive packages, which has also has an adverse effect on the economy. But worldwide, some people have used statistics, some too have come out with mathematics. As mathematics provide the framework for the theoretical basis of scientific research. Ahmed Ita, 2001, he developed a susceptible, exposed, quarantine, infective, and recovered model. So here he assumed that the pandemic started in Nigeria because there wasn't any diffusion aspect. So he divided the population of Nigeria into the susceptible, those who do not have the disease, but they are prone to the disease. And then they expose people who have the disease, but they cannot transmit. Because according to the background of the disease, when someone come in contact with a COVID-19 patient and contract the virus, he cannot also transmit to another person onset. He has to stay for a period of time before he or she can transmit to another person. Then he also observed another subgroup, the I. That's those who are COVID-19 patients and they can transmit. And then those who are taken to the isolation center or who are quarantined. Then from there, and then those who are recovered. So he separated the population into 5 compartments. Then Rampine 2001 also did a similar studies, which is not quite different from Ahmed Ita 2001. For him, he obtained the basic reproductive number and also find the effect of the parameters the effect of the parameters on the basic reproductive number, which determines whether the disease will spread or not. Then ZEP 2020, IBO 2020, all of them have used some existing models to describe the pandemic of COVID-19. But all these studies were not done in China, where we can say that the disease started from there. So from the WHO, as soon as an infectious disease crosses one geographical area to another, then become a pandemic. So once it crosses one geographical area, then there is a diffusion. There must be a diffusion part, which is the movement of the people from where we have the cases to a place where we do not have the cases. And all these people did not consider the travelers, those who move into the respective countries. So it informs us that we must what? We must incorporate what? The diffusion part, which will account for the special effect in the spread of the COVID-19. So the way forward is we now develop our model, which we call it SEIQI_DR, which incorporates the diffusing susceptibles, the exposed and the infected person. That is, on March 12, 2020, 2 people came to Ghana, one from Turkey and one from Australia. They came with a disease, so they were tested positive. So here, where they came from, there were some cases. And by that time, Ghana did not have any case. It means that they came with a disease, and that is the diffusion from the high concentration to a low concentration. So here, our model inculcate that. That's our first objective. And when they came, some Ghanaians came in contact with them. So that's the susceptible, because by that time, nobody had contracted disease, but we can contract it. So these people who contracted it, some people moved to the north, some people also moved to the south. Like a typical case when a man boarded a public transport to Wa, and the government ordered the security to chase him. So that's in the northern direction, and that is the why. Then another person who is a chief also moved to Asante Achim, who also greeted a number of dignitaries. So here there is also a horizontal transmission. So this informs us that our diffusion should be in 2 dimensions, that's X and Y. So the X here represent the horizontal transmission, and the Y represent the vertical transmission of the disease. So in our model, we also look at the stability analysis of the fixed point of the model. Since the model is a nonlinear mixture of PDEs and ODEs, we do not have analytic solutions. So here we have to fall on a fixed point solutions and determine whether they are stable or not. And also our third objective, we also look at the effect of the parameters on the basic reproductive number. That will enable to know whether the disease will spread or not. So the basic reproductive number will determine whether the disease will spread or not. We want to know the key factors that influences that threshold condition. And also the fourth objective is to look at the wavefront solution, that the effect of the travelers who came into Ghana. Because of time, I will go to my model. So here, the Ghana population here is divided into 7 subgroups. The S is a susceptible, That's those of us who do not have the disease, but we can contract, and the E is exposed. Those who have the disease, but they cannot transmit onset. They can only transmit after a period of time. So after a period of time, they move to the I, which is the rate that is given by the V. And then this I are the people who can transmit the disease. That's the COVID-19 patient. But these people, some of them go for the testing or through the contact tracing. The Ghana Health Service is able to get some of them and put them in isolation center. That's the kill, the quarantine. But not everybody who is comfortable of going to the isolation center. So some of the dignitaries like the Chief Justice, he went on self-isolation. So such people are put in this class, that is the I1. Then another part of the COVID-19 patient, for those people, maybe he doesn't know that he has a COVID-19 or he has tested positive, but because he has a motive that once I've gotten COVID-19, I must also transmit the disease to another person. So those people are the I2, the deviant group. That's the I2. So those people are still in the system spreading. But with all these three compartments, some of them are able to recover from the diseases. So when they recover from, for instance, R1, I1, they move to the R, and then some of them also die, and some also die naturally, not from the disease. And the quarantine, a similar trend. Then from that, we get the following one, a mixture of PDs and ODs. So the X represent the horizontal transmission, the Y represents what? The vertical transmission. That's those who move to the north and those who move to the south. So here, in order to reduce the parameters and also make it proportion, because the population of Ghana keep on increasing. So we non-dimensionalize by using equation 2. Now, let me go to my findings. Here, we observe that the speed of the travelers, when the speed of the travelers is equal or greater than 2√2 times the root of d squared times n squared, where the d2 is a ratio of the coefficient of diffusion of the travelers who came with the disease over the travelers without the disease times the sum of the natural death rate, the quarantine rate, and then the deviant rate. If it's data, then there will be a special spread of the disease. And also from our stability analysis, our fixed point, we realize that if there is no disease, this will be a fixed point solution. If there is a disease, the equation 14 will be the solution. And are the disease free? That is when there is no disease. We want to know whether somebody comes maybe to Ghana, whether there will be a spread of the disease. So in order to do that, we have to derive the basic reproductive number, which is given by equation 15. So here, we now ascertain the effect of the parameters on the basic reproductive number by using the equation 16. So we estimate our parameters, and these are the parameters we estimated based on data we had from the Ghana Health Service, and these are our initial conditions. So here we plot our graph, and we could see that the S here represent the susceptibles. So here the susceptibles are going down. It tells us that the people are getting the disease, because once someone get the disease, he moved from the S class then to the E class. That is why the yellow graph goes up and down. So here, as the exposed is going up, then the susceptibles are also going down. Then Then we estimate the value of the basic reproductive number based on the data we had from the Ghana Health Service, and we had 2.2. But because this is a human being, so we have to approximate it upwards. And this implies that in Ghana, one COVID-19 patient transmits the SARS virus to 3 people. Now, based on our sensitivity analysis, we could see that 1.6 is the highest. That's the incubation rate. Has the most influence in determining whether the disease was spread or not. And also, we realize that the endemic phase point is not stable. That means that the disease will be with us forever. Otherwise, if it's stable, then the disease will be under control. Now, conclusion. We are able to modify a classical model by incorporating the diffusion coefficient to account for the spatial inflow of travelers into the country. And also we realize that if the speed of the travelers is equal or more than the square root of the inner product of the ratio of the coefficient of diffusion of COVID-19 patients to that of the susceptible inflow into the country, and the ratio of the sum of the natural death rate, deviance rate, quarantine rate, isolation rate to the incubation rate, then there will be a special spread of disease. And here we also realize that there is free fixed point which is unstable, and that with that we derive our R0, would tell us that the disease is still spreading. So every day 3 people get COVID-19 from 1 COVID-19 patient. And we also able to determine the threshold condition for which the disease will be under control. And based on our sensitivity analysis, we realize that the rate at which COVID-19 quarantines recover from their illness has the least influence. And then the incubation rate has mostly affect the basic reproductive number. Thank you.
Thank you very, very much, Dr. Barnes, for such a thorough, extensive, comprehensive, rigorous, and exhaustive presentation. Please, Dr. Barnes, keep your eye in the chat section for any questions that the audience might have for you. Now, as we know, honors and rewards fall to those who show their good qualities in action. And the Ghana Science Association would like to honor such individuals for their distinguished work. Let us invite the president of the Kumasi branch of the Ghana Science Association, Dr. Jacob Agbenhoabi, to present the awards to deserving individuals.
Thank you, our wonderful moderator. Can you hear me? Okay. Before we present the award winners, I would like to thank everyone who participated, who joined us live on this Zoom, and also those who have joined us through the various social media channels, YouTube, and others. We want to thank all those who submitted abstracts and those who are presenting posters, as well as the oral presenters. The award categories we have that for department, author, poster presenters, as well as special awards or recognition for individuals who have made meritorious contributions to the growth of Ghana Science Association. And these include the past executives. Remember, this webinar marks our 10th GSA research seminar and poster presentations. And a lot have been done in the past by individuals who made wonderful contributions. We also appreciating the contributions from our sponsors, key sponsors and collaborators. The evaluation team is working hard to get us that of the poster presenters and the oral presenters. So this will be presented last. However, I will start with those for special recognition. So we have special honor and recognition for meritorious contributions. On the list, we have the recipient, Professor Mrs. Rita Akosua Dixon, Vice Chancellor, KNUST. Let's give her a round of applause. Next recipient, Professor Ellis Osu Dabo, Pro Vice Chancellor, KNUST. Next, we have Professor Leonard K. Amekuji, Provost, College of Science. Next, we have Professor Mark Adom Asamoah, Provost, College of Engineering. Followed by Professor Christian Ejari, Provost, College of Health Sciences. Professor Ben B.K. Banfo, Provost, College of Agric and Natural Resources. We have Professor Abwaje Menya. I must say Professor Abwaje is also known as our father and is also our patron. Professor Abwaje Menya. We also have other patrons, Pastor Professor William Otu Ellis, Professor Mrs. Ibok Odro, Professor R.C. Abedu, Professor Joseph Nketia Bechi, Professor Kwesi Obri Danso, Professor R.K. Nkum, Professor Mrs. Victoria Pearl Jogbefia, Professor Sylvester K. Danwa, Professor William Gariba Akanwiriwak, also our national president. Professor Isaac Williams Ofosu, Dr. David Benkuma, Professor Peter Tumesi. I must say it was during Peter Tumesi's time that we started with this one-day research seminar poster presentations. Professor, we appreciate your initiative. Next, Dr. Ebenezer J.D. Belfort, Dr. Mrs. Gloria Matanda Akabreu, Professor Nathaniel Osu Bwedi is also the national president currently. Professor Patrick Adofojo, Dr. Mrs. Linda Ofori. And also, you know, we always do this with collaborators. And our key collaborators over the years, we appreciate you very much. Standing tall is College of Science. The previous provost and the current provost has been massive in supporting our Obina. And currently, and as of last year too, they keep hosting us, providing the facilities and things we need. We are more than grateful. College of Science, special recognition for your meritorious contributions. Next, we also have College of Health Sciences, KNUST, College of Engineering, KNUST, College of Agric and Natural Resources, KNUST. We also want to appreciate CSR, the Council for Scientific and Industrial Research, for the meritorious contributions, collaboration, and support received all these years. We also want to appreciate National Sports Authority. National Sports Authority. Last year's webinar was jointly collaborated and sponsored by them. We also appreciate Tech TV, KNUST. Now we are doing all these things live. Tech TV has been instrumental. The multimedia. I must say that today's award has been proudly sponsored by Nabis Plus Company Limited and Tadia Kiss Me Hair Food. 3rd Year Limited. They have massively supported with the wonderful prizes you are seeing. So we appreciate them, and we are inviting more to get on board with this kind of sponsorship and collaboration. Now, from there, we move to the department. The overall best department with the highest number of abstracts goes to the Department of Food Science and Technology. Let's give them a standing ovation. They have been very consistent in winning this award, and we appreciate their continual contribution to the abstract. Followed by Department of Chemistry, KNUST. Well done. I think last year they were the best. This year they are maintaining their position by going second instead. Now the 3rd best goes to Department of Biochemistry and Biotechnology. Well done, Biochemistry and Biotechnology. We go to the best authors. The author with the highest number of abstracts. We have received 85 abstracts. 85 abstracts. The best, highest, overall best had 12 abstracts, representing 14%. And this goes to Dr. Lawrence Sherrington Bokwe. This year, our best author goes to Lawrence with the highest contribution. Followed by 2nd best, Professor Mrs. Ibok Odro. In fact, since the inception of this award, Prof has always been on the list. That shows her continual commitment and contribution to the scientific output in terms of abstract and papers. The 3rd best goes to Dr. Marina Aferiba Tando. Thank you. At the moment, I am waiting for the scores of the oral presentations. Okay, they are in. The oral presenters. So, where is it? So now the overall best oral presenter with an average score of 69.5%, the best oral presenter goes to Patrick Ofori. Patrick Ofori. The 2nd best oral presenter goes to Josephat Opon Mensah. The 3rd best oral presenter goes to Raphael Nyako Morrison. Thank you very much. We are waiting for that of the poster awards. And when the evaluation team submit, we will update you. In the meantime, moderator, take over. Thank you.
Thank you very, very much, Jacob. Unfortunately, we have to bring this webinar to a close. And I believe we've learned a lot and look forward to the 11th conference, which will hopefully not be online. Thanks for staying with us throughout the presentations. Sorry for any technical challenges that encountered at any point in time. We would like to invite the chair of the local organizing committee for this particular webinar, Dr. Mrs. Augustina Angelina Silverton, to give us a closing remark and some take-home messages from this webinar.
Thank you so very much. It's been 2 wonderful days of action-packed, challenging issues, thought-provoking, exciting, and a lot of information to take home. Indeed, you will all agree with me that yesterday and today have been packed. We have a lot to think about or think through. We have new information, which I hope will rekindle energize, and importantly, spur us on as far as research is concerned. I must indicate that when the LOC was tasked to put this webinar together, we were in limbo on as to how the program will run and importantly, how it would end. But I am sure you would all agree with me that we have executed our mandate fully. But like I indicated, we have all been challenged. Yesterday was very good, right from when the Pro-VC, Professor Elisowusu Dabo, gave his welcome address. He already pointed a couple of challenges and importantly, a number of opportunities that scientists could take on in order to understand the nature of the virus causing the pandemic and importantly, its transmission patterns. So right from there, I think I knew that we were really on a very good start. Indeed, he further encouraged us as scientists to identify opportunities presented by the pandemic. And he also indicated that really, as scientists, it is very important for us to ask all the relevant questions in our quest to find solutions to fight this pandemic. And beyond this pandemic, I think the ones yet to come, whether they may come as pandemics or as epidemics. Our first keynote speaker, a vibrant speaker, Dr. Kwame Sapon Asiedu, in highlighting how countries have received vaccines, how they have, in terms of receiving the vaccines and introducing the vaccines, have led to the less or few hospitalizations and mortalities, also focused on Ghana and further also challenged us to undertake some high throughput research studies. And I think that even on what he already prompted us to do as scientists, the two main research areas he prompted us that we needed to already take charge and delve into. For me, I strongly believe that some scientists are already looking into such areas in this country. So for me, I think that the future does not look that bleak. Our second keynote speaker took us through how COVID has impacted our food security, our agriculture, and our nutrition. For her, I think she challenged the local government and the national government that it is very important to connect scientists with researchers and farmers, and importantly, bring these three groupings together to enhance agriculture, food, and nutritional safety during this pandemic and beyond. In addition to these two keynote speakers, we also listened to carefully selected oral presentations, and importantly, their selected presentations synced so very well with the sub-thematic areas as chosen. On day two, I think expectations were very, very high, obviously because of the selected sub-thematic areas, which included the fact that in terms of herbal medicines, whether we are really there as Ghanaians or as Africans. But I think Professor Mohamed Mutuchelu did justice to that. He also challenged us as scientists and decided or encouraged us that it's very important to offer some level of training, formal training, to our traditional herbalists, and importantly, help build their capacities in formalizing their practices on technological and engineering pathways as far as COVID-19 is concerned. Are exciting two keynote speakers, Dr. Lord Anthony Basin and Engineer Professor Mark Adoma Samwa, carefully took us through the endless list of technological advancements. They cited examples such as diagnostic methodologies currently employed. They took us through a couple of applications and everyday things we have already introduced into our lives as far as technology or the use of technology is concerned in our quest to limit surges during this particular pandemic. Our last keynote speaker also carefully selected and asked to speak to the topic, socioeconomic responses to COVID-19, gave some highlights on some of the socio-economic policies implemented by the Ghanaian national government. I think we've had a lot of information to take home. We have learned a lot. I hope we have made a lot of contacts. And we definitely need to appreciate a couple of people. And I take this opportunity to appreciate our conference chairman in the person of the provost of the College of Science, Professor Leonard Amekuji. Thank you so very much, Professor, for being the backbone of this webinar and almost all the webinars run or conducted by the Ghana Science Association, the Kumasi branch. We also appreciate our special guest of honor, the Vice Chancellor. Thank you, Madam Vice Chancellor, for your continuous support. Thank you also, our Pro Vice Chancellor, for all the exciting things and the behind the scene advice you have been given to the Ghana Science Association. Special thanks goes to all our special guests, all the provosts, our collaborators, the national president of the Ghana Science Association, all the executives. We appreciate all our keynote speakers. We definitely appreciate all of you. Thank you so very much for making time, spending time in preparing all the exciting addresses you gave us. Thanks also goes to our oral speakers, our oral presenters, energetic young men and women, and as well our poster presenters. We also appreciate the support of all our participants. Of course, if you hadn't joined us, I doubt if we could have even organized this program in the first place. Our media or our friends in the media, we can't thank you more. We appreciate you. In fact, I also need to appreciate our proud sponsors. They have done a yeoman's job. Our special thanks goes to KNUST. We appreciate URO, KNUST, all the media houses on KNUST campus. We appreciate College of Science, College of Arts and Natural Resources, College of Health Sciences, College of Engineering. We appreciate ABN Group of Companies. We appreciate GOIL Ghana for giving us support, Tabia Betes. We appreciate NASB Plus Company Limited, multimedia group of companies. We cannot thank you more. And of course, Media General and all the various sponsors and sponsorships or support we have from various individuals. Of course, we also need to express our thanks to the local organizing committee. Thank you, committee members. A very big thank you to our moderators, our two exciting moderators, for helping us run this show. And of course, we also appreciate all those who supported us in organizing this 10th webinar for the Ghana Science Association, the Kumasi branch. Thank you all, and may God bless all of us. Thank you very much.
Thank you, Dr. Silverkin. I believe that the remaining results for the poster presentation is in, and Dr. Jacob would like to announce them.
Thank you. So we now have the results for the poster award winners. In fact, the evaluators have done a great job. It has not been easy because the posters are online for viewing. You have to scroll through a number of them. And at this point, though these best 5 are awarded, all other presenters should feel very proud for participating. Let's give them a round of applause. All those who submitted posters. In fact, you are the heroes. The overall best, first, we have Stephen Opoku Efriye. Second best, Caleb Nketia. Third best, Abigail Kusiwa Adoma. Fourth, Gertrude Adoma. Fifth, Gideon Adai Kusi. Congratulations to the poster award winners. Now, to all others who participated and who presented, we say thank you and congratulate yourself as well. Without you, we will not have this webinar. On this note, we would like to encourage everyone to continually support GSA in the various capacity you can. When there's a call for participation in workshop, conference, meeting, scientific abstract, and so on, do not hesitate. Because see yourself as without you, nothing will move on as GSA. Recently, we did a review, a survey asking for people to evaluate themselves in terms of membership status. Few have been able to respond, and we are going to surprise those people who take things serious by responding. They also get special awards as exemplary members. So some people have scored high, at least 80 and above, in the simple category of, do you pay your dues? Do you attend meetings? Do you present a paper? Or do you review a paper? Are you serving as an executive? What do you call it? On any committee or a rep, a patron. So looking at the 10 simple criteria outlined there, we encourage everybody to improve your membership status where we fall short. Especially from the survey which we'll share later, it was shown that when it comes to publication in the journal, that has scored low points. And also when it comes to reviewing for the journal, as scientists, these two things we can't afford not to do. Though we are doing well with conference presentations, but when it comes to publication of our scientific findings, let's encourage and do more. On this note, we want to say thank you to everyone, especially our executives and our LOC. In fact, I like the work to describe the work done. Dr. Silverkin and the team, the executives are most grateful. We appreciate your wonderful job done with the excellent display and the beautiful awards everybody's seeing. Thank you, and long live Ghana Science Association, long live Kumasi branch. We hope to see more ahead. Let me hint you, this year, Kumasi branch is hosting the biannual conference. We are the national host this year. Somewhere around September, the LOC working on this, LOC led by Dr. Kingsley Badu. They are working hard in the event. The call for abstract and things like that will be announced soon. So we encourage all of us to get on board and get ready. September, we have a greater things to show. Thank you, and I wish you all the best. Thank you. Moderator, take over.
Thank you, Dr. Jacob. So in the chat section, we've put the link to the evaluation form. So we encourage attendants to please follow the link and give us your feedback, what you like, what you didn't particularly like, things that you wish you could have done differently, so that we can improve going forward. We would like to invite Dr. Amalabi to give us a closing prayer.
Shall we pray? Thank you, Father, for being with us. Thank you that the webinar has come to a successful end. We thank you for everything. Help us to implement everything we have learned and help GSA go forward. We commit the rest of our week into your hands. We ask that you take absolute control. We give you all the glory and honor. In Jesus' mighty name have we prayed. Amen.
Amen. I believe that we can turn our videos on and give each other a wave. I don't know if you are going to take a picture like we did
yes,
today.
screenshot.
So please make sure your video is on.
Hello.
Unfortunately, I'm not very familiar with a lot of faces. Is our cameraman ready?
Many people have not turned on their faces.
Just like people don't want us to see their faces. I want to see Professor Mabedu's face, but his camera is off. Okay, thank you all very much once again, and see you next year.
Bye-bye.
Bye.
Sure.